So I want to acknowledge that we are hosting this session on the unceded and ancestral territory of the Coast Salish peoples, including the territories of the Musqueam, the Squamish, the Tsleil-Waututh Nations, and the Métis Charter Community of the Lower Mainland region. And all of you around the province and elsewhere are on your respective territories and lands, and acknowledge the blessing and fortitude with which we live on these lands. Next slide. So it gives me great pleasure to introduce Dr. Chris McIntyre. And many of you have heard Chris speak before, but he's a professor of medicine, of medical biophysics and pediatrics in the Robert Lindsay Chair of Dialysis Research and Innovation at Western University, previously called UWO, but now called WU. He's a Lawson scientist and associate director at the Research Institute and the director of the Lilibeth Caberto Kidney Clinical Research Unit. And as many of you know, Chris has been passionate about trying to figure out why dialysis therapies might, whilst they save lives, also hurt organs. And he's spent a long time trying to work out best methods by which to test this, as well as what the truth is about the various toxins and things that are circulating and how they impact. He's also been a mentor to over 100 scientists over the last 15 years in different veins, medicine, physics, etc. And it's really terrific to have him. He's been passionate lately about salt. And he's also one of our CanSolve scientists and has a research program within the Canadians Seeking Innovative Solutions to Chronic Kidney Diseases. And so, Chris, I'll turn it over to you so you can tell us the salty truth about sodium accumulation in chronic kidney disease. Thanks.
Lovely. Thank you very much, Adira. Sorry, I can't be there in person. This sucks so badly. Hang on, I've done. Is that coming up okay?
Yes, it's just you need to go into slide mode at the bottom.
Get rid of all of that. There we go.
Yep.
There we go. We're in business. Lovely. Well, thanks very much for giving me an opportunity to talk to you all this morning. As I say, sucks something terrible that can't actually go anywhere, but this breaks up the day anyway. So what I want to talk to you about is sodium accumulation and really the evolving key role that we may be appreciating that salt may be the oldest and most important of the uremic toxins. See, actually make that go forward. There we go. So what is it that we thought we knew about salt? Well, this is Arthur Guyton. And Arthur Guyton was a remarkable man. He was going to be a surgeon. He was doing his first year of residency, and then he got polio. And so rather than sit around doing nothing, he invented a new kind of motorized lift, and he invented the first electrically controlled wheelchair with a joystick. And then at the end of that, he realized that surgery was not going to be possible because of the physical damage he'd suffered from his bout of polio. So he pivoted to become a physiologist. And then not only did he make an amazing textbook, which he did 14 versions of, and unlike these easy peasy textbooks now where all you do is you corral a series of authors, he actually wrote all the damn stuff himself. So he needed a vast panoramic knowledge. But that was helped because a lot of what went in it, he actually discovered. And he was key in understanding and bringing forward our understanding about cardiovascular control. And he did this through a series of absolutely beautiful, elegant experiments with a series of very unfortunate dogs. But he also elucidated the role that salt plays in all of this and described the linkage between salt ingestion, expansion of extracellular water, and hypertension. And how even though that relationship could be modified by reducing renal function or diuretics or limiting salt intake, everything that happened occurred within that same perfect cycle. A salt load was ingested, it had an effect, it was excreted. And this is still true. None of what I'm going to tell you means what Arthur Guyton said wasn't true. The reality, though, is it was not the full truth. And the additional insights to this may help us look after our patients better. So what do we know now beyond Guyton? Well, through the 1980s and beyond, people started to find evidence of extra accumulation of salt without being associated with water. This initially was in animal experiments and initially was actually involved assaying the degree of sodium in tissues by charring and using inorganic chemistry. And then in 2000, a very detailed short-term 3-week study was done in a series of normal humans in a very tightly controlled metabolic ward. And during this period of time, they were given increasing salt loads and demonstrated absolutely that with increasing salt loads, there was an increasing positive sodium balance. However, when they measured extracellular water using absolute isotope dilution techniques, the sodium load was not associated with an increase in extracellular water. There was a dichotomization between salt and water. Moving forward, this was looked at much more closely by Jens Titze, who decided very bravely to buddy up with the Soviet space program. And at that time, they were running a simulated Mars mission where they were putting their cosmonauts into an earthbound simulated environment for the approximately 500 days trip to Mars. So Jens realized that they had created a perfect metabolic cage for humans for the study of long-term changes. And he did a deal with the Russians. He sourced all their food, and he was able to put them on a increasing and then decreasing sodium load diet in this perfect chamber, and monitor blood pressure, fluid state, weight, and endocrine consequences over this full period. And what he discovered during this period of time is, although sodium was accumulated, again, there was not significant expansion of extracellular water. And although blood pressure did go up a little bit, it was nowhere near as much as would be predicted by the short-term dog experiments of Arthur Guyton. So salt was being accumulated and it was not being associated with water. So if that's true, where is it? Well, you can imagine that the requirements to be able to stick salt somewhere without water was probably a vital factor in us being able to get out of the seas and get onto the land. If every time you ingested salt, you had to lose water to get rid of it all, you were going to be very poor at water conservation. So these mechanisms were probably developed teleologically. So where can you put the salt? Well, there are 3 main places. The bone, which is a long-term storage, muscle, which is predominantly intracellular and appears to be medium-term storage in terms of how we can move it in and out, and the skin, which is able to buffer a lot of sodium. And that's the very miscible pool. That's where sodium moves in and out very fast. And within the skin, it associates with proteoglycans and is held within that gel without the storage of associated water in an extracellular manner. Now, this field then took another step forward when we got to the point of, instead of inferring where the salt was, could we actually visualize and measure it? And the way we could do that was by adapting magnetic resonance imaging. The scanners we use clinically are working on protons. And they work on protons because the signal to noise ratio is good. You get a lot of signal, and that enables you to get high resolution images. Just like with a radio, it's possible to retune that scanner and listen to the signal that comes from other atoms, in this case, 23 sodium. The disadvantage of that is the signal to noise ratio is absolutely garbage. So you're working on a signal which is only about 1/200th of water. So that makes it technically much more challenging to be able to get a signal and reconstruct images. Now, over the years, the blue bars are the papers that were being published on sodium spectroscopy. That's no attempt to create an image. That's just creating a NMR measured sodium level. Then through the 1990s, efforts associated with increasing field strength of magnets started to be able to produce meaningful images from sodium. And these were largely related to tissues such as the leg. Because the signal to noise ratio is so bad, it's very important to get the coil as close to the tissue as possible, and ideally a tissue that is not moving around with any kind of respiratory or contractile artifact. So the leg became the ideal substrate to look at. It also has the advantage that the leg contains skin, muscle, and bone, which is the three compartments that we're interested in. So when you do that, these are the kind of images that you get. This is a cross-section through a thigh, and these are patients who have normal kidney function, reduced GFR, but not needing dialysis, hemodialysis, and peritoneal dialysis. The little circles here, these are vials that are filled with sodium at known concentrations. And that allows us to calibrate our systems and allows us to then choose regions of interest and get absolute measures of the concentration of sodium within that tissue. These images are heat maps. The more it glows, the more sodium it is. So for instance, with this hemo patient here, you can appreciate the intense level of sodium storage. You can also see why trying to assess this by biopsying people is very difficult to do, because the sodium is not always distributed fully evenly through these tissues. So depending if you biopsy this bit or this bit, you'd get very different reasons. The imaging was validated by taking amputated limbs, scanning them, assessing the sodium content in them with the MRI, and then taking the limb and ashing it, and then doing inorganic chemistry and flame photometry to have an absolute measure of the sodium level in it. So it has been validated against observed biological reality. So does it accumulate? These are data from a smaller initial study that we did, looking at the level of salt in the skin. Again, healthy people, reduced GFR, hemodialysis, and in fact, in this study, peritoneal dialysis being associated with the highest levels of concentration. So it was there and we could measure it. These are data from a larger study, around 140 patients, where we've elucidated this further and confirmed those findings. There is a relationship with GFR. It's not particularly strong, and we'll come to some of the determinants of this in a minute. But this study is the first one that's actually also looked at the levels of sodium in the tissue of children. Children, as age is an important factor, have less than adult healthy patients do. But we also included a cohort of children with established CKD. And to give you some idea, the image on the left is a normal 7-year-old child. Again, this is a heat map image. The more it glows, the hotter it is, the more salt. This is a 7-year-old child with a GFR of 18 mils a minute from congenital nephrotic syndrome, with a much higher level of sodium within their tissues. There's a lot of difference between the different children, and that's because children often have salt-losing nephropathies as well as etiologies that classically make them retain. So we're breaking into that further now. When we took this cohort and were able to do some multivariable work on it, because up to this point, most of the studies have been too small to be able to do meaningful multivariable, the key factors that drive it are low serum albumin, being fat, being inflamed, and having high levels of glucose, and that includes glucose within the non-diabetic range. Albumin is particularly important, and this may be down to the fact that albumin also buffers sodium in the circulation, and the lower your albumin, the more sodium there may be within plasma-free water that's available to be able to be placed within tissues. Now, other etiologies add extra problems to this. So for instance, heart failure is a clinico-pathological situation where there is intense congestion and intense retention of salt and water. So if we superimpose heart failure onto this, we actually compound the problem. So in this study, we took a group of patients with cardiorenal syndrome and measured their tissue sodium. And then we took a group of patients with CKD with the same level of renal function, but without heart failure. And those patients had much less sodium within them. In fact, the cardiorenal patients have as much sodium in their tissues as patients who have no meaningful renal function and are actually requiring hemodialysis. So there are other cycles of neuroendocrine processes that are also driving this and loading salt on. So the next part, if we've safely stored that sodium away, we've locked it, surely it's not bad for you. Well, this is the problem. It really is a uremic toxin. And when the sodium is stored within those compartments, it is not biologically inert. It is associated with an expanding and increasingly appreciated group of negative biological effects, many of which we've formally attributed to the uremic state. So if we look at the skin, for instance, when the sodium is stored and bound to the proteoglycans, what that does is it recruits and activates immunocompetent cells, macrophages largely. These then release a wide variety of molecules that are known to have aberrant effects on the cardiovascular system, on blood pressure, on cardiac remodeling. And these molecules are absorbed and distributed back to the circulation via the lymphatics. So when we look at patients who are hypertensive versus not hypertensive, the hypertensive patients have a lot more skin sodium. And if we look at how many drugs those patients needed to control their blood pressure, the more drugs you were needing, the higher the level of your skin sodium. But this salt's everywhere. It's also profoundly pro-inflammatory. And so if we look, for instance, at serum albumin, in this case, thinking about it as an inflammatory marker, the lower your serum albumin, the higher your level of tissue sodium. And that sodium also is rammed into the skeletal muscle. So there are a variety of other symptoms that our patients get commonly, such as itch and restless leg syndrome. And the more sodium there is in those tissues, the worse those symptoms are. So it seems to be associated with patterns of harm that map to cardiovascular risk, the principal killer of our patients, and constellations of symptoms that are also characteristic in the severe uremic state. There is also, of course, sodium that is acting in the Guytonian fashion, expanding volume. This is a study that we're doing at the moment that's taking detailed CTs of dialysis patients' chests, extracting all of the tissue that is not blood containing and measuring the volume of blood that's currently within the pulmonary vessels. The more blood there is in the pulmonary vessels, the more breathless patients are, using, in this case, a modified MRC scale of questionnaires. In fact, you get a very tight level of agreement. And effectively what we're looking at here is a CT scan to measure pulmonary hypertension. But if we look at these patients, they also all underwent sodium MRI scanning, and the patients with abnormal sodium accumulation are all at the wrong end of both breathlessness and expansion of volume. But salt may have other effects on breathlessness as well that we haven't appreciated. We've known since the 80s that salt loading can drive bronchospasm and asthma. We know that from epidemiology. This was looking at the amount of salt that children ate against the severity of their asthma. We looked at that the higher the level of salt you were loaded with, the lower your circulating level of plasma catecholamines, and indeed a down regulation of appropriate adrenal receptors, priming you to bronchospasm. When you took bits of bronchus out and you looked at their sensitivity to a stimulant such as warbane, the more sodium loaded those tissues were, the more likely they were to be spastic. And indeed, when you took asthmatics and did histamine challenge to their asthma, the more sodium loaded they were made, the more sensitive to salt they became. So in the 80s and early 90s, there was an expanding story related to salt-sensitive asthma. So could that be playing a part in our patients? Well, to look at that, we've been applying another form of MRI scanning, in this case, hyperpolarized noble gas MRI. What we do is we take xenon, and in a machine, we magnetize the xenon. And that turns it into an inhalational MR contrast agent. So the patient lies in an MR scanner, breathes in from a bag, takes in the hyperpolarized xenon, and that allows us to, in extreme detail, look at the ventilation of the lung throughout the entire chest. In this case, the xenon is marked up in blue, and this is a normal patient showing very well distributed ventilation throughout. These are images from dialysis patients who have no history of lung disease or exposure to smoking. And as you can see, there are multiple elements throughout it where actually these patients are not ventilating their lungs. Now, we then repeat these scans after we've administered bronchodilators, and many of these areas of ventilation actually improve. So you've got bronchodilator responsive changes in ventilation. And that's interesting because if you think about it, there are an awful lot of patients that we have clutching their salbutamol inhalers who we repeatedly tell them there's no evidence you have asthma, but they swear blind to us that it helps. It might just be asking the patient, might help us to actually understand what's going on and actually believing what they tell us. So those are harms of shortness of breath. But what about the harms associated to the excess of cardiovascular mortality that we see? We've done a further study where we took these patients, did sodium MRI, but then did echocardiography to look at the type of morphology of their left ventricles. We know that with each change of category from normal geometry to concentric remodeling to concentric hypertrophy, and then finally eccentric hypertrophy, this escalation of morphology is associated in our patients with worse outcomes. And when we compare the level of tissue sodium in these groups of patients, the more tissue sodium you have, the worse the remodeling within your ventricle. Now, let's talk a bit now about the microcirculation and about the absolute key role it takes. And this is where this part of our work joins the kind of work you might have heard me talk about before, which is the dialysis-induced organ ischemia. There is a belief that your blood is in contact with your endothelial cellular surface. This is not true. Your endothelium is covered in a glycocalyx, and it's the glycocalyx that interacts with blood. And in you and I, we actually have about 1 liter of glycocalyx within our bodies. That glycocalyx is made up of a variety of compounds, but is largely proteoglycan based. And this is a tremendous buffer for sodium. It also regulates the transfer of water, the permeability of the capillary surface, and damage to it directly mediates endothelial dysfunction. Now, this is vulnerable. Study just done in the Netherlands demonstrated that during a hemodialysis session, raising the plasma sodium actually causes this molecule here, syndecan-1, to be shed from the glycocalyx and recovered in the circulation. So indirect evidence that sodium loading during a dialysis session can actually damage the glycocalyx, which could mediate endothelial dysfunction. Now, as I said, the glycocalyx is key in determining the level of capillary permeability, and therefore may help to explain why our patients develop extravascular water at levels of pressure that in you and I, it wouldn't happen. But key is whether or not it actually might be involved as an additional priming factor to demand ischemia during dialysis as a consequence of induction of microcirculatory dysfunction. And what we've spent some time now looking at is the fact that all of the cardiovascular system is vulnerable. And as humans, we are one single contiguous endothelial surface that's investing a variety of organs of importance. So one thing that hurts for one organ is probably going to hurt for the others. And then when we dialyze people, not only are we providing a tremendous hemodynamic stress, we're also producing a tremendous oncotic stress as we mobilize and move oncotically active compounds. Now, to see that in action, we've been working in our lab, setting up a small animal model of hemodialysis. In this case, this is dialyzing a 190-gram rat. We use the femoral artery and the tail vein to provide our extracorporeal circuit. And then we've in-house manufactured a miniaturized dialysis setup, including miniaturized hemodialyzers themselves. The blood pump speed for this is 0.5 mils a minute, for instance. The dialysate flow is about 0.5 to 1 mil a minute. At the same time, we take some of the skeletal muscle of these animals and we expose it, we transilluminate it, and we use intravital microscopy to actually visualize the microcirculation during dialysis. And we can numericize these images to get red cell velocity and the proportion of the field which is being perfused. So what you're seeing here is individual red blood cells going through a capillary network in patients who are in rats who haven't been put onto dialysis yet. These are the same field after 1, 2, and 3 hours of dialysis. And as you can see, there is an increasing reduction in microcirculatory flow. In the first 2 hours of dialysis, there is no ultrafiltration. This is the consequence of whatever oncotic changes we have, whatever changes in sodium we have, and whatever reactions there are between blood and an extracorporeal circuit. So yes, the removal of fluid makes it much worse, but actually there is evidence even without that, that there is harm from dialysis. Now, just to go quickly, we've looked at a lot of that in humans. We've done studies where we've used cardiac PET scanning to measure myocardial perfusion and demonstrated that dialysis significantly reduces this. We've repeated those studies using cardiac MRI and have confirmed it and shown that there is a relationship between ultrafiltration rate and this damage, but there is also a reduction in perfusion before there is meaningful removal of fluid. We're now doing studies using ultraslice CT that allows us to do myocardial perfusion with a spatial resolution of about 1 millimeter and have been able to demonstrate exactly the same features. Big images, so it slows up my Mac. There we go. And we've looked at the effect on other organs. In this case, this is a reduction in perfusion of the kidneys during dialysis, and whether or not this actually contributes to the loss of residual renal function that is characteristic of our hemo patients. We can actually take these images and work on the kinetics of removal of dye and calculate GFR very accurately, demonstrating that actually GFR falls meaningfully in these patients with some residual. It recovers after dialysis, and then a subsequent dialysis, it happens again. So you've got serial insults, which presumably are cumulative. Very importantly, the brain is highly vulnerable. This is from a study that we've just completed. We're finishing the analysis now. In this study, we dialyze patients within an MRI scanner, and we study a variety of features of their brain during dialysis. In this case, this is the perfusion of the brain, using a technique that allows us to label the blood magnetically and not have to give any contrast. Red is lots of blood flow, blue is not much blood flow at all. These are the brain images before dialysis of actually this individual here, Lloyd. This is what his brain looks like after 3 hours of dialysis. The level of reduction here is about the same as you see in a watershed ischemic infarct. And indeed, when we do markers for inflammation. This is a combination with a kind of PET scanning at the same time. The top images are normal brains, and these are dialysis brains, absolutely on fire with inflammation. Now, do we think any of this is important? These are data we haven't published yet because we only finished doing them yesterday. This is looking at a cohort of patients that we've had who are all on dialysis, looking at their outcome independently determined by their sodium loading over a period of a couple of years. And indeed, those patients with higher sodium load appear to have significantly worse survival. So if it's bad, and if it's stored, are we just looking at it from epidemiology, or can we actually think about how do we get it out? The balance of sodium during dialysis is determined by the difference between your plasma water sodium and what's in the dialysate. So this is a group of patients, and this is looking at the movement of sodium either from blood to dialysate on this side, or actually dialysate to blood on the other side, as a function of what their plasma sodium was before they started dialysis, because all of these people were dialyzing against the same 138 millimole sodium. So the higher the level of your plasma sodium, the more is removed. But actually, for many patients with lower pre-dialysis sodiums, not only do they have inadequate removal of sodium, they actually move salt from dialysate into the blood. We actually salt load during dialysis. Now, Jens did a small study where he could actually demonstrate before and after dialysis reduction in tissue sodium. So here, the whiter it is, the more sodium there is before and after dialysis. So this sodium is miscible. It does move from these compartments. So how could we influence that with dialysate sodium choices? Well, this is the association of skin sodium and the prescribed dialysate sodium. So the higher your dialysate sodium, the more loaded those patients are. But obviously that can be confounded by indication and its observation. In this instance, we had patients randomized for a year to 2 different sodium dialysate baths, 137 and 140 millimole per liter. And at the end of that period of time, those patients dialyzed against the lower dialysate sodium have significantly lower levels of tissue sodium than those dialyzed at 140, both in widespread use within any of our units, and neither, I think, would be considered particularly high or particularly low by most clinical users. Now, sodium's got to travel across the dialysis membrane. And can we do anything to make that dialysis membrane more permissive? What happens is not all the salt that you ingest is actually even available to be removed. Some of it binds to proteins and other ions and is not diffusible. The other problem that happens is as we dialyze, you coat the membrane with donor protein, your own proteins. And those proteins are positively charged, and that means there is electrostatic resistance to the movement of sodium across the membrane. So the actual size of the pore that is not impeded on electrostatically might be quite small. And for that reason, a proportion of the sodium is rejected. And this is down to the Gibbs-Donnan effect. And it's everywhere between probably 3 to 8% of the ingested sodium is not cleared because of this electrostatic resistance. Now, new generations of mid-cutoff dialysis membranes are characterized by having larger, more evenly shaped pores. So is it possible that in that setting, because the pores are bigger, the effective area of the pore that is not impinged on by significant electrostatic forces is actually larger, and might these membranes be more permissive to sodium? So here was our first index case. This was a 72-year-old man who had been on dialysis for 18 months and had intractable pruritus to the point where he was requesting to stop dialysis and die. He was a highly compliant individual, tiny weight gains, did everything as he was told, cared for by a very loving wife and a very involved Greek family. He had every one of the standard interventions and nothing made any difference. When we looked at the level of tissue sodium within his leg, he actually had the highest level that we'd ever recorded. We then converted him to one of these newer forms of dialysis. And 3 months later, the level of sodium within his tissues was radically reduced. And indeed, it was reduced almost to the level of healthy controls. That's the little red lines here. During that period, his itch completely resolved, and even actually how his skin physically looked resolved. Now, these are data from a study that's ongoing now, but this is looking at patients who were the same patients when they were established on conventional high flux dialysis, their skin sodium, and after conversion to these different membranes. So not everybody, but a significant number of patients over, in this case, a 6-month period, had reductions in their tissue sodium. Could we use drugs to take sodium out? These are data from patients with cardiorenal syndrome, not on dialysis. Loop diuretics are a good way to remove water, but aren't a very good way to remove salt. And indeed, the higher the level of Lasix that they're on, the higher the level of their sodium concentration. That's in stark contrast with those patients who have both been on Entresto and critically on SGLT2 inhibitors, even though these were the patients who were clinically the most severe. Now, obviously that could help us utilize the ability for the kidneys to clear sodium, helped with issues like putting them on a SGLT2 inhibitor. But a dialysis patient can't do that. They haven't got the kidneys to do it. So could we have a way to directly remove sodium from patients without removing water? So this is direct sodium removal. And we're developing this with co-workers in Yale and a company based in Belgium. And this is using the peritoneum as the way to remove it. But instead of using standard PD solutions, using PD solutions that contain no sodium whatsoever. So when you do an exchange with a conventional high glucose bag, even though you remove a lot of water, you actually mobilize only about 1 gram of sodium. If you do the same exchange with 0% sodium, you actually remove 5 grams of sodium, somebody's entire daily intake potentially. Over that period of time, this did not result in hyponatremia, probably as a consequence of these enormous tissue reservoirs of sodium, and hopefully the depletion of those reservoirs. Now, the exciting thing about direct sodium removal is it's 2-part. We want to combine the fluid, but we also want to combine it with a different way of delivering dialysis. So we don't burden patients with 2 forms of dialysis, and we don't further damage body image and feelings of normality. So this is being delivered through an implanted system. We implant a portacath with a catheter into the peritoneum. So at the end of dialysis, twice a week, we puncture the skin with a portacath needle and we instill the fluid into the belly. That then acts to remove the sodium. We then use an implantable pump, which was initially developed for the management of intractable ascites, which has 1 catheter within the peritoneal cavity and the second catheter implanted into the bladder. The pump is programmed, so having had several hours worth of dwell, just like the sump pump in your basement, it takes the fluid from the peritoneum, deposits it into the bladder, and is passed out like urine. So the aim of this is to allow us to utilize direct sodium removal, but actually to not increase the burden on patients. We're looking at this initially in hemodialysis patients and in patients with cardiorenal syndrome who have intractable disease. Now, there's 2 more organs to talk about, which I'm going to go through fairly quickly. The first is it possible that we could look at what's happening directly to the heart? In animals, we know that sodium deposited in the myocardium is intensely profibrotic, intensely. And is it possible that it is a direct uremic toxin? I told you that sodium is difficult to image if you don't have the coil right on the tissue and if the thing is jumping about. So imaging it in the heart is very difficult. So we've been at it about 3 years. We've had to build our own coils. We've had to build our own code. But these are the first images that we're generating of the heart with sodium. So in this, you're cut through coronally. This is very high levels of sodium in the cartilage of the sternum. The green is sodium within the blood. And here, the blue, that's the left ventricle. We can then take a proton cardiac MR image and fuse the two, and that will allow us to define our regions of interest and quantify directly the level of sodium within these tissues. We also can do it directly in the brain, and we're very interested in this because studies we've been doing have shown that during dialysis, acutely, we generate cytotoxic edema that causes white matter injury and drives ongoing cognitive impairment. And this is also driven by oncotic stress. These are brains showing before and during dialysis, with all of these green and yellow areas being the development of new cytotoxic edema during a single dialysis treatment. That also means the brains swell, and unfortunately, it also means the CSF volume falls, reducing the buoyant effect on the brain and taking the swollen brain, making it heavier and ramming it through the foramen magnum. And we wonder why our patients complain of feeling like their heads are in a bucket, they have terrible headache, confusion, sometimes even delirium. But the last organ I want to talk about is the kidney. At the moment, we focus functionally on glomerular filtration rate, but we know that tubular function is at least, if not more important, particularly in predicting the development of CKD. So could we use sodium MRI to actually study sodium handling within the kidney and the fundamental process that happens within the medulla of concentrating the medulla with sodium to allow you to recover fluid and osmoregulate? So in this case, again, we had to build new physical equipment and new code. And here you see the proton image of the kidney. And this is the sodium image with very clear delineation between the medulla and the cortex. Again, we can fuse the images. This works in normal patients who are skinny. It also works in people who don't have normal renal function and who are bigger. This is a 94-kilo man with a GFR of 19 mils a minute. And we're still able to fully quantify this corticomedullary sodium gradient. So does this actually track physiologically? This is an image of somebody who was fluid restricted overnight and have done the appropriate urine concentration, urosmolality up to nearly 1,000. Within 45 minutes, with a fluid challenge, you can see the sodium is dumped out of the medulla, the urine osmolality plummets, and as the water load is excreted, the kidney reconcentrates the medulla and increases urine osmolality. You're actually visualizing those physiological processes in man. And graphically, that just demonstrates the change and how it tracks the urine osmolality changes to the imaging changes. And we're now hoping to apply this in a whole range of states, understanding diuretic resistance, understanding how to use diuretics in patients on dialysis, and what degree and what type of residual renal function might identify those who will benefit. We want to look at AKI diagnosis and predicting recovery, and CKD diagnosis and treatment response. If you have heart failure, you don't do a myocardial biopsy to find out what's wrong, you image. And here we are, still relying on tissue. We think there's a lot of possibility to understand what's happening in transplantation, tubular disorders, and stone formation, of which sodium handling is a key component in nephrolithiasis, and also the effects, particularly of issues like tolvaptan in polycystic kidney disease. So thank you for putting up with all of that. I'd just like to thank everybody involved, the team, I'd like to thank the CanSolve network that have been instrumental in funding and providing context for this piece of our work. And I'll put one last cheeky little bit there, which is if anybody is interested, probably into next year, we're strongly considering taking on another team member. This would be looking at a combined clinical training fellowship with a research degree focusing on cardiorenal medicine. And if anybody was interested in thinking about it, feel free to reach out to Adira or to me directly. So with that, I'll shut up. Thank you very much indeed.
Thanks, Chris. Just if you stop sharing, then we can have the.
There you go.
There you go. Fantastic. Like, just invigorates the soul to think about all the different things that we can do, because what you've done is you've unmasked the fact that there's lots of potential, not just understanding, but treatment options for our patients. I think it's actually remarkable to think for all the damage that we do during dialysis, how well they stay and how functional so many are. And so there's something in that resilience as well. There are a couple of questions, so I'll start asking those. And again, thank you for really an enlightening and fascinating talk. And for the residents and fellows, and I always have emphasized the fact that if we understand the physiology, we'll get the treatments right. And so taking us back to physiology is really fantastic. So a couple of questions. Sodium bicarbonate. We give sodium bicarb to our CKD patients, and theoretically that's supposed to make things better. And they seem not to gain a lot of weight, etc. In your work, have you seen a difference between the sodium ingested or infused with chloride versus bicarbonate? And can you comment on that?
So we were interested in pursuing this more, particularly when Vivirima as a acid binder looked like it was being developed further, but that's stalled rather. So that stream of work has been put to one side at the moment. I think the lack of weight gain and the lack of precipitation of heart failure has made us quite lazy and complacent with our use of sodium bicarbonate, particularly when the studies that exist show that if you want to make a difference, you actually have to give a lot of sodium bicarbonate. And you're increasing the dietary sodium load by something over a third to 50% of what they'd be taking in dietetically. So even though there may be benefits, what you're gaining on the swings, you might be losing on the roundabouts. And I think we would very much like to understand those consequences better. We are looking now to see whether or not we can actually retune our MRI and actually image chloride. And then actually we'd be able to close that thing off. But chloride's even tougher to do than sodium. So have to wait for that one, I'm afraid.
Yeah. So a couple more questions. Can you comment on the results of the SOLID trial, read the lack of findings on LV mass outcome and poor tolerability of the low dialysis sodium that was observed?
I think using low dialysis sodium in a non-individualized fashion is very problematical. And dialyzing our patients against a unit-based sodium level is madness. The problem is knowing what it should be is very difficult to do. And my concern in that study is it was confounded because there would be the effects on volume, there would be the effects of absolute tissue sodium, but also there would be the effects on the lower sodium having more unstable dialysis sessions, resulting in more ischemic injury and ischemia driving remodeling and changes within the myocardium. So I think because the study wasn't founded in an in-depth appreciation of the complexities of the physiology, we shouldn't be altogether surprised that there are mixed messages that emerge from it. And poor Adira has heard me bang on about this a lot, but randomized controlled trials are very bad ways to find stuff out. When you've evolved your question and you've worked out your effect size and you've worked out who might benefit, they are a very, very good way to see whether or not they are therapies that are worth doing. But trying to elucidate physiology from a randomized controlled trial is very hard work.
Thank you. That is like music to my ears. You cannot understand physiology with an RCT. You can prove a physiological concept with an RCT.
And God forbid trying to use epidemiology to understand physiology.
Yes, yeah, yes. And everyone know, yeah, we can talk about hemoglobin another time. So there's a lot of PD patients with a bad itch. Is the imaging available for those patients, and how available is that low sodium PD dialysate?
So the ultra low sodium is not to let the secret out, is actually 10% dextrose. We are developing a 0 sodium icodextrin that would be a better longer term option. But the initial studies to see whether or not it's something worth doing, we're just using plain 10% dextrose. So it is possible that we could consider augmenting a conventional PD regime with occasional direct sodium removal, because the protocols we're running at the moment are only one exchange twice a week. So you're not replacing like for like. And the studies that were done with lower PD sodium actually changed all of the bags to a lower sodium. And PD is a very poor way to take sodium out, not least because the Gibbs-Donnan effect is huge, because there's so much tissue between the capillary and the peritoneal cavity. The level of protein and the level of resistance within that electrostatically is enormous. So that's one of the things that we're starting to look at now. But we've only just got the REB up and running, and we've actually just recruited the first hemo patient yesterday, but we don't have any data on it yet.
So parenthetically, we do individualize dialysate sodium here, and this is sort of two comments. You know, is it too, how precise do we need to be? And do you think it's too crude to just select and adjust dialysis concentration based on a patient's own pre-dialysis sodium, or are there some other ways that you might advise, or are we developing those techniques?
So there's nothing more complex than biology. You saw the significant difference in somebody being on 137 and 140. That's a relatively small difference, but because the dialysate volumes are so high, the mass transfer involved is very high. So that suggests to me we actually need to be quite precise. The problem is, how do you set that level? Because it's not your serum. This is like going back to calcium and the idea that serum calcium was telling us anything about calcium loading. Right. Serum sodium doesn't tell us very much about sodium status. It tells us more about free water status. Yeah. And actually, it's determined, the diffusion, by the plasma water sodium. So it's actually a compartment of a compartment, which is the critical one. So I think we're going to have to get more intelligent about it. And we may even having to look at things like measuring the tissue sodium to determine not only what to set it at, but to monitor response. And that we don't have one thing that we leave forever. So I would love to have a better answer for that at the moment. It's almost certainly lower than we're using now.
Yeah. Yeah, I think it's a good, yeah. And the individualization is there, but it's probably not as sophisticated as it ultimately will be over time.
But certainly if you dialyze somebody against a dialysate sodium that's higher than their serum sodium, don't be surprised you're not moving salt. So if you did nothing more than at least just take the top of it off, I think we would be helping people.
Right. So there are a couple more questions. So one is, can you comment on a little bit more on your experience with using high HDF for increased sodium removal? Does it have to be coupled with the new membrane to be more effective, or?
So hemodiafiltration is not a good way to remove sodium. And that's because we give very large volumes of replacement generated online, which is dialysate that you just turned it up to 140 millimole per liter. So it's not a very good way to remove it. So the new membranes are actually working just in straight dialysis mode. They actually do have a degree of internal filtration because they have some back filtration within the dialyzer itself. And we're actually being able to replicate that within our animals as well, using that membrane. But no, this is just a straightforward substitution. Now, at the moment, there's only one maker, but then at one point, there was only one high flux dialysis maker. I think it will be a new category of dialyzer. Great.
And there's another question. As the skin is a reservoir for sodium, is it conceivable that a whole body bath, like a swimming pool, could reduce the reservoir?
Well, I even at one point considered the insanity of the idea of having sauna as an intervention. And then when I actually bothered to look up the physiology, you realize that very quickly your skin regulates and starts to actually sodium hold in. Because remember, your skin, your dermis, is like a kidney. You've got a little loop of Henle all the way through your skin. It regulates. So yeah, it's I'm open to anything.
So you know what, it's just 2 minutes before the hour. What a fantastic way for all of us, I think, to start the day, to sort of think more deeply. So for us, it's much earlier than you, as you well know.
Yes.
But really, it's great to think about the new technologies that are born from a better understanding of physiology. And I think it really makes us think a lot about what we do and what we don't do and how we might do it better, and some of the challenges that we face. But thank you for all the thought that you put into this, and hopefully you'll inspire many of us, especially some of our younger trainees, to really think about the physiology and how they can apply things in a way otherwise. So thanks for making the time, Chris, and for all the work you're doing.
I'm happy to talk to anybody offline as well who wants to talk.
Yeah, no, that's great. I'm sure there'll be many, many questions. So thanks so much.
stuff.
If you were here, we'd have a little round table, but next time.
That'd be nice.
Next time.
Next time, maybe.
Next time. Yeah, thanks.
All right.
So
Be
much,
well on everybody. Bye-bye.
Yeah, thanks. Bye-bye.